Welcome everybody to a new presentation in the series of radiographic interpretation of lesions, whether they were radiolucent or radio-opaque. And in this presentation, we are going to discuss the jaw lesions which are associated with impacted tooth or teeth. What we are having, what we are trying to do is to have an idea about setting a diagnostic guide for the radiographic assessment. How would we put a differential diagnosis if we see a radiolucent lesion or a lesion, whether it was radio-opaque or radiolucent, that is associated with an impacted tooth. I found this article, which I based this presentation on, the jaw lesions associated with impacted tooth, a good article that you can find the topic here, the article, and it's your web or URL where you can just look at this article, have an idea. Actually, the article has very well discussed the lesion based on a revision of several articles that were written on this topic, plus textbooks that have been which were discussing the lesions, whether they were radiolucent or radio-opaque, that may be seen, how to put them, how to differentiate them, if they put it all together in a differential diagnosis, if they were present or associated with an impacted tooth. Not necessarily always an impacted tooth, but the majority of the lesions that will be discussed in this presentation actually will be discussing those lesions which are associated with either an impacted tooth or teeth in different places of the arch, whether of the arches, maxilla, and the mandible. The authors of the article actually they have summarized those lesions based on their frequency, based on their age and the agenda, the tooth which is affected, the jaw, the location, plus that they have tried to give a description of the lesion, which is if it is found, whatever lesion that has, they have tried to describe such lesions, and that what they found actually is that lesions that were found according to their frequency is starting with the Dentigerous cyst, calcifying odontogenic cyst, the Unicystic or mural ameloblastoma, ameloblastic fibroma, adenomatoid odontogenic tumor, and they have also recognized the keratocystic odontogenic tumor, calcifying epithelial odontogenic tumor, ameloblastic fibro-odontoma, and odontoma proper. So what they found is that they have found around 10 lesions that have been mostly reported to be associated with an impacted tooth. If you can either refer back to the article, or you can have a summary of these lesions as stated in these tables. Now, let us start from according to the sequence of lesions. First of all, we will start with the dentigerous cyst. Dentigerous cyst is found actually so frequent, and the dentigerous cyst is mostly found between in the second and the third decades of life. Excuse me. And the second and the third decades of life. And these lesions tend to be available more in the in males more than in females, and usually in most of the cases, in around 70% of cases, 60 to 70% of cases, it is associated with an impacted tooth. However, you might find it also without the presence of an impacted tooth. Mostly you will find it in the mandible in most of the cases and in the posterior side of the mandible. When you see a dentigerous cyst or suspect a dentigerous cyst, you would expect that this lesion will be a well-defined, corticated lesion that has a sclerotic border, and usually, as we said, you always find it with an associated tooth. Typically, you will find it with the lesion starts from the cemento-enamel junction and then spreads all around. The lesion causes expansion, not necessarily painful expansion, and it causes thinning of the lower border of the mandible, and it may cause resorption of the teeth which are present in the area in a close proximity to the area. As you can see here, this lesion, which is well defined, sclerotic corticated margin, which is present in the lower posterior mandible, associated with this impacted tooth. The lesion may push the tooth by its pressure as it increases in size, and it may cause resorption of the associated teeth, as you can find in this OPG. Another radiograph, which is also seen, there are two impacted teeth, lower molars at least, but there are other impacted molars in this, for this patient in particular, and you can see that the lesion is present. If you trace the lesion, you will find it that it is present exactly at the cemento-enamel junction, and then it houses or it encloses the crown of the tooth, and this is typical of the dentigerous cyst. It doesn't go beyond the cemento-enamel junction, and here in this lesion in particular, it is not as big as the one that we saw earlier in the previous radiograph, and there is no apparent resorption of the so far of the distal root of the lower 7. However, the lesion is unilocular, very well defined, and it has a sclerotic border. The second lesion, which you can also find with an impacted tooth, according to the frequency, is the calcifying odontogenic cyst. Calcifying odontogenic cyst, you can find it between ages between 20s and up to 60s. You can find mostly in the late 30s, and the male and female ratio in this lesion is equal, and you will find it also with an impacted tooth. However, it is less as frequent as that of the dentigerous cyst. Around 20% of the cases, or mostly 20% of cases, you will find it with an impacted tooth. However, you may find it isolated. It has no relation with an impacted tooth. The lesion is mostly seen in canines, and you can also see it in the premolars as well. And the maxilla and the mandible again are almost affected the same in the same rate in this area. As the lower mandible and the upper maxilla are most common where you can find these areas. However, they may go back posteriorly to the premolar area. Radiographically, these lesions would appear as a well-defined It could be either a unilocular or a multilocular radiolucency, and where you can see a radio-opaque foci inside the lesion, which gives it the multilocular appearance. So, a calcifying odontogenic cyst is a cyst which is well defined, may cause pushing of the teeth. However, the resorption of teeth is unlikely as that of the dentigerous cyst, and it is mostly found in the anterior maxilla and the mandible. It doesn't go back to the levels of the posterior teeth as we have seen with the dentigerous cyst, and you can see traces of radio opaque foci or foci, which gives this, hence the name is given, the calcifying odontogenic cyst. The calcifying odontogenic cyst may also be seen with impacted upper molars, where you can see a unilocular radio opacity over here, as you can see in this area, associated with an impacted tooth. And the degree of calcification of this lesion varies. So you may see faint trabecules, or you would see a condensed area of radio opacity in the later stages. So the calcifying odontogenic cyst and the calcifying odontogenic tumor, as you will see in the upcoming slides, they have a similar appearance. However, the age group differ from between those three lesions, and then we have to take this into consideration. Other lesions that might be seen with the impacted teeth or separately is the unicystic or the mural ameloblastoma. These are seen in, like in 10% to 15% of the lesions which are present in the jaw. They tend to shift to the patient's age in 20s, and males are more than females. Mostly you can see it associated with the third molars, and the mandible is the common place for these lesions to be found in the posterior mandible. If it was if you want to radiograph, see it in the radiograph, the lesion would appear as a unilocular, scalloped. Sometimes it is macro multilocular, pericoronal. It could be interradicular, or it could be a periapical radiolucency. So the unicystic ameloblastoma, the position is not necessarily associated with the crown. You might see it in the interradicular area. You might see it also close to the crest of the bone, and you might see it as a unilocular radiolucency. Scalloping of the margin is common in these cases, as it tends to expand into the bone. However, it doesn't expand as much as the ameloblastoma proper. The ameloblastoma, as we will see in the coming slides, they tend to be more aggressive. This lesion is not as aggressive as that of the ameloblastoma. This lesion also tends to cause bodily movement of the teeth in the vicinity, and they might also cause root resorption. Another case of a unicystic ameloblastoma, where you can see it here as up till here. You can see this is the lesion. It is extending from here. It goes up to the posterior border of the ramus of the mandible. It involves the sigmoid notch, coronoid process, and then it goes all the way up till here, goes down to the anterior border of the ascending ramus, and then it involves the area of the molars, premolars, and it goes down to cause thinning and expansion of the mandible, and here it is associated with an impacted molar. This is a more aggressive type of unicystic ameloblastoma, and it has caused the movement of the tooth, thinning of the mandible, the complete thinning of the posterior rebus of the mandible, and it has caused the resorption of the teeth which are in the area that is of the 6 and the 7, which are present in this radiograph. Ameloblastoma, on the other hand, if it is not unicystic, it will assume the typical honeycomb or the soap bubble appearance. The honeycomb or the soap bubble appearance is due to the presence of compartments, the bone compartments or the cavities within the cystic growth of these cells. The tumor, the ameloblastoma, is mostly, you would find it in the 30s and the 50s, and the male seem to be more affected than females. The lesion tends to affect the mandible, in most of the cases in the posterior border of the mandible, associated with third molars, and the lesion would assume the multilocular appearance. In some instances, it would appear as a unilocular appearance. However, the typical appearance of these lesions usually would appear as multicystic, multi-compartment, which was described as the soap bubble appearance. The lesion tends to cause expansion, relatively aggressive lesion in the advanced lesions, and it causes resorption, it causes thinning of the lower border of the mandible, and it causes marked expansion of the affected jaw. Another lesion, which is the ameloblastic fibroma. Ameloblastic fibroma is a mixed tumor where you can find it in the with certain prevalence into younger age group. Typically, in the usually you can't find it in the combined or the mixed dentition, and the top age is in the 20s. Males seem to be more affected than females, and actually it can affect any any tooth area, and the mandible is not more to be affected in the posterior border of the mandible. So you don't see it always with a canine, you don't always see it with an impacted premolars, you can see it with any tooth. The ameloblastic fibroma, it could be pericoronal, it could be unilocular, it could be a multilocular radiolucency. However, the multilocular appearance is also predominating in these areas, as you can see here. In the this is a young patient, and let's say around 7 years of age, and you can see that the lesion has caused marked resorption of the associated teeth, plus the bodily movement of the deciduous teeth which are present in the area, and the typical radiolucent scalloped appearance of the margin. The other entity, which is found mostly in the maxilla and the anterior part, however you can find it also in the mandible, in the premolar area, and in the parasymphysial area, is the adenomatoid odontogenic tumor. This affects patient of the young age group in the 20s, and the females here in this disease entity are more affected. It has a specific affinity towards the canines. However, the other premolars can be affected also, and the maxilla, as we said, it's more common. These tumors in the radiograph would appear as a corticated pericoronal, so it has, as you can see, it has a cortex margin. The radiolucency has a corticated margin which surrounds the coronal part of the tooth, and typically you would see areas of radioopacities which are scattered throughout the radiolucency, through the major radiolucency of the lesion. These lesions tend to cause tooth movement. However, they are unlikely to cause the tooth resorption of the adjacent areas. The other lesion, which is also common, is the Keratocystic odontogenic tumor, which was previously called the odontogenic keratocyst. This is a tumor which is found, you can see it between the 20s and 50s in the patients. The male are more affected by this tumor than females. The posterior part of the mandible is the common site for such tumors, and the tumor in the radiograph would appear as a well-defined. It could be, as you can see, you can trace the margin, unilocular or a multilocular radiolucency, and you can find scalloping, as you can see here, of the margins of the tumor, because it doesn't expand in a uniform way, but it goes like it invades the area in a scalloped margin, and it has a corticated margin, and you would see traces of keratin-like materials that, if they mature enough, they will appear, which would appear as radioopacities within the central radiolucent cavity of the radiolucency of the tumor. These tumors, if they tend to spread in an anterior-posterior direction, so they do not cause that much of expansion as that which is caused by the ameloblastoma. However, they would invade the mandible, starting from the posterior part in a more anterior part, as you can see in this lesion. However, there is expansion and this on the buccal surface, but when you look, you would see that the lesion has extended into an anterior-posterior direction. Another case of keratocystic odontogenic tumor, where you can find here it is not associated with the tooth, so it is not always associated with the tooth, and you can see the anterior-posterior direction or the expansion of the lesion. These are more destructive than the ameloblastoma. I don't say that ameloblastomas are not destructive, but they tend to invade, to destroy more of the mandible, because they go in an anterior direction. And you can see that the lesion, which has a scalloped, typical scalloping, as you can see over here, it has caused expansion and thinning of the mandible, and then it goes back to its scalloping border, where you can see that it has crossed the midline, and it has caused the resorption of the associated teeth. And you can see that the lesion would appear, give a multilocular appearance with traces of keratin formation. Now, by the way, these lesions are not always, this could be another case of ameloblastoma, right? But the final judgment or the final word would be for the histopathological examination. But if you would see a lesion like this one, you would consider the keratocystic epithelial, keratocystic odontogenic tumor. The other lesion, which is seen more into the posterior part of the mandible, and you can see it also in the third molar area, and the females are more affected than males in this case, and the age group is between 40s to 50s. This is the calcifying epithelial odontogenic tumor. This is another mixed tumor in which there is calcification within basically it will start as a radiolucent margin, and then it starts to laying down of calcific material inside that would give the final appearance as a mixed radiolucent radio-opaque pattern. The calcifying epithelial odontogenic tumor can be found in other areas of the jaws, whether they're in the maxilla or the mandible. However, it has more affinity towards the posterior maxilla, towards the posterior mandible. It may cause a painful expansion of the affected jaw. Another case of calcifying epithelial odontogenic tumor, you can see it here associated with an impacted lower 7, and this has actually it has a soft tissue capsule which has, as you can see over here, it has grown inside the oral cavity, and it is typically found on the superior border of the crown of the tooth, and it tends to push the crown of the tooth downwards, as you can see in here. The calcifying epithelial odontogenic tumor, here it gives the calcifying material, it gives an amorphous radio-opaque or radio-opacity within the otherwise radiolucent tumor. The other case, which is another mixed tumor, is the ameloblastic fibro-odontoma. Ameloblastic fibro-odontoma is seen in the second decade of life. The males and females are equally affected. It is not necessarily associated with molars or canines or premolars. Any tooth can be affected. Sometimes it doesn't have any. It is not associated with any other impacted tooth. The maxilla and the mandible here are affected equally. However, there is an affinity towards the posterior side of the maxilla or the mandible, regardless. This lesion would appear as a well-defined radiolucency containing various amounts of radio-opaque materials. The radio-opaque materials is actually due to the tooth-like structures which are enclosed within the general radiolucency of the lesion. So ameloblastic fibro-odontoma basically would start as a radiolucency of ameloblastic tumor. Then it will be invaded by a growth of a mixed fibro-odontoma, that is a fibrous and odontogenic cells that would mature enough, and they will be calcified, and it gives you this typical appearance of a tooth-like structure as you can see in this area. This might cause a painful expansion of the area. It may cause resorption and expansion of the involved area. The last entity in this in these lesions is the odontoma. Odontoma basically would start as a radiolucency, and then it will of course this it is divided into two types: the compound and the complex. The compound odontoma has a more affinity toward the maxilla. The complex has an affinity towards the mandible. And the compound odontoma that is in the maxilla, you would expect it to be seen in the anterior part of the maxilla, while the complex odontoma, it has an affinity towards the posterior part of the mandible. It is seen in the patients in 20s. Males and females are equally affected. It doesn't have any affinity towards a tooth. However, it might be seen with premolars and molars. And sometimes it is not associated with any other tooth. Now, this would appear as a well-defined radiolucency in the beginning. Then it will, by the start of the formation of the tooth-like structures, it will change into a mixed radiolucent radio-opaque structure, and then when it is completely mature, it will appear as a complete radio opacity, as you can see in here. And always these lesions, because they are odontogenic in nature, they are surrounded by a radiolucent border that would surround it from the surrounding bone. Another very large case of odontoma over here, where you can see that the lesion is well defined and it has the typical soft tissue capsule that surrounds it or separates it from the surrounding bone. Now the lesion, of course, this is a very big lesion, but you can see that there are so many teeth-like structures giving the typical. Now this is a mature lesion. It gives you that typical what they call as the teeth in bag appearance, as if you have put a large number of teeth in a single bag and you are carrying it, and this is the typical appearance of a complex odontoma. You can see lesions which are less severe than this one. You can see it in the maxilla, whether in the palate, anterior maxilla. You can see it associated with an impacted tooth, as you can see it here in the lower 6 and the lower 8, and there could be a lower 7 over here. No, the lower 8 is not erupted in this patient, so it is associated with the lower 7 and the lower 6, and it has caused bodily movement of both teeth. Even the canine has been pushed, and of course it is prevented from being erupted. Now with this slide we come to the end of this presentation. I hope it is beneficial. I have gone fast. I would recommend again, if you go back to the article, which is in the first slide, there is a complete description of the lesions which are associated or which are seen here. The 10 lesions, these are the Dentigerous, calcifying odontogenic cyst, Unicystic ameloblastoma, Multicystic ameloblastoma, Ameloblastic fibroma, the adenomatoid odontogenic tumor, Keratocystic odontogenic tumor, Calcifying epithelial odontogenic tumor, Ameloblastic fibro-odontoma, and lastly the odontoma. Thank you very much.